on my anesthesia rotation. And I mean, I don't think it was what you were describing you were going to have done, but yeah.
Turbinate reduction is the classification of the
Okay.
procedures. Let me share with you my screen.
It's kind of crazy how normal you look like for someone going into this area of your face and doing surgery. Like, I feel like I would imagine you would be so black and blue here, but
Yeah, so the conventional surgery, um, they go in and actually cut off. Let's see if I can create image a new tab. There we go. So what is the turbinate? The turbinate is the bone and the soft tissue inside of the nose that helps to heat, humidify, and disinfect the air as we breathe through our nose. So oftentimes what happens based on allergies, anatomical variations, or what have you, uh, the soft tissues actually close, and there's just very poor airflow through here. So the conventional surgery is to go and actually cut these off. That's called a turbinate reduction. The sequelae of that is something called empty nose syndrome. This tissue right here has a lot of function. The reason we have these in our nose and the reason why they are shaped the way they are is very important. And if we reduce them, or if the ENT cuts them off, there's a drastic increase in airflow, but a drastic decrease in heat, humidification, and disinfection, and all of the things that happen as a result of those three things not functioning. So the surgery that I had done is called the MIST technique, minimally invasive surgical technique, where he goes in and he just reduces the it's not the fat, but think of it as liposuction almost. He doesn't touch
sure.
he doesn't touch the bone. He doesn't reduce or remove the outer surface of the tissue. He goes in with a radiofrequency probe and actually removes all of this extra inner tissue or submucosal tissue. What that does, it heals very well with very little bleeding. It's not painful at all because he's not into the innervated area of the nose. Honestly, most of the discomfort I had, he did a septal repair, so he straightened out my septum, very similar to what he did here. He didn't remove any cartilage, but I did have a deviated septum, and he straightened that out, and I think that's probably where my very mild pain and discomfort came from. But the reason why I sought him out was because he is pioneering this procedure called the MIST technique. And if you guys are interested, I can send you the articles that he's written in the otolaryngology literature, trying to get ENTs to realize how easy this is, how little morbidity there is, and how effective it is without any side effects. And I'm just going through the normal. Everything's inflamed in here right now, so I can't breathe through my nose. So I'm an obligate breather right now through my mouth, obligate mouth breather, and it's pretty jarring how bad it is to not be able to breathe through your nose. So it's going to be worse before it gets better. Oddly enough, the day after the surgery, I felt like I could breathe better than I ever have. Then the inflammation set in. So that first day, if that first day was a glimpse at what I'm going to be like when this inflammation comes down, I'm more than happy to go through this challenge right now.
I wonder if you'll develop like transient gingivitis through this. I mean,
I
obviously you're gonna
Yes,
brush but you know what I mean? Like, I wonder if you're gonna have more gingivitis from obligate mouth breathing.
I definitely think so, and I've already had some tartar buildup as a result.
Mm.
I don't typically get tartar buildup, at least not at an accelerated rate, without me putting my teeth in on the camera. Just trust me on
Yeah,
the fact
all
that,
good.
take my word for it. I have more tartar than I normally would. So this procedure is why I think we should send patients down to see his group. So he has 3 or 4 other otolaryngologists that are equally as trained in this particular procedure. There's other things that he did in there. He cryogenically froze a nerve that comes down. I forget the name of the nasopharyngeal nerve, maybe. But there's a nerve in there that controls the blood flow to the mucosa. That nerve is controlled by the sympathetic and parasympathetic activity of the body. You ever notice when you're sick that you're stuffy on one side and not the other, and then 2 hours later it switches over?
Yeah.
It's that nerve is the one that controls that. It's a cyclical thing. It has to do with circadian rhythms and things I don't know at this point anyways. But it is cyclical in nature based on every few hours. And people who have my kind of septal defects often have the nerve doesn't work right. So he cryogenically freezes one side, which kind of releases the nerve, so to say, because there's an inhibitory PNS reflex. So he freezes one part of the nerve, which then restores natural function of the nerve, and that lasts for 2 years. He's going to do that in a couple months once all the swelling goes down.
That's crazy.
And then he's going to do, I think he said the superior turbinate he can't get to because the inferior turbinate's so big. So the first surgery is the inferior.
Oh yeah, I
and
remember
middle.
seeing, the CBCT, and Lavani said, right, one side's Libby, and it was like huge. The other side's Lavani.
Yeah, exactly. Very, very significant difference.
Yeah.
Yeah, I'm using the NECADE. Let me show you guys what that is. NECADE Sinus rinse. This guy here. This is really cool. So this ENT came up with something akin to a neti pot. It's a squeeze bottle, and there's a hole in the top here, and you fill this with distilled water, and then there's this I think it's like sodium chloride and bicarbonate mix that neutralizes the pH to the pH of your tissues. I don't know if you've ever gotten water up your nose when you're in a lake and it burns like hell. That's always happened to me, but I never really understood why. The pH of water is very different than the pH requirements of the nasal mucosa, and it ends up burning. So this little packet here has some salts that produces a pH that's very comforting for the nose. And then you fill this bottle up and you basically just squeeze it, and you're essentially creating a flow of water in one nostril and out the other. And then some of it comes out the back of your throat. So it's a really good way. It sounds extremely disgusting, but it's actually a good feeling once it's clean. Good way to clean the nose. I recommend you guys try this out. There's a lot of value here. Maybe you don't need to do it, but I think there's a lot of patients that can benefit from this.
I mean, I'm going to need this. I suffer from just like seasonal allergies, and I think just some days kill me. I think this is, I mean, I've used a neti pot before, and we have kind of that system here, but this almost just seems easier, to be honest.
Yeah. Does the neti pot burn?
No, because it's got that same, it's a packet that you
Okay.
add distilled water to.
Great.
I'll look it up. Actually, that packet looks the same. I wonder if it's the same brand. It's just in a different.
Yeah, he's got a whole line.
Wait. Sorry, I was gonna ask what you were just saying about the tissue burning. That just kind of reminded me about the bicarbonate thing with local. Is that the same concept?
Yeah, bicarbonate is a buffer. What is a buffer?
Yeah. Okay, that makes sense.
A buffer is essentially a chemical molecule that helps to stabilize the free hydrogen ions, which is the acidity part of whatever compound you're trying to neutralize. Bicarbonate helps to kind of suck those up and bring it to a pH that's more in line with what you're trying to do. Henderson-Hasselbalch equation is the equation that kind of governs that whole arena of chemistry. When we use it for local anesthesia, what we're trying to do is get the pH to something more physiologic. So physiologic pH, don't quote me on this, but I think it's somewhere between 7.1 and 7.4. When we have infection and inflammation by definition is acidic. So when we have a nerve that's sitting in acidic tissue, the pH is much lower. Then you bring in the anesthetic, and the anesthetics are designed to work at a neutral pH or a physiologic pH, but the pH is much lower. So looking at Henderson-Hasselbalch's equation, when you're dealing with local anesthetics, you have the free base, which is essentially the part that travels through the phospholipid bilayer. It's the hydrophobic component. That's what permeates through the neuronal sheath, whereas the free ions are more hydrophilic, and they tend to stay outside the neuronal sheath. They don't actually penetrate the nerve, and you get less anesthesia. So that's why sodium bicarbonate in local anesthesia is so powerful. So sodium.
So why doesn't someone create an anesthetic that works at a lower
Good question.
pH?
$1 million idea.
$1 million idea right there, right? For just in cases of
You got to be a chemist.
infection and
So it has to do with the shelf life of the anesthetic and the preservative. So the preservative needs a certain pH, and if the anesthetic doesn't have that pH, then the shelf life is drastically reduced. So in theory, you could do that, but the shelf life would be very, very minimal. And people have tried selling that over the years, and the shelf life is so minimal that it ends up expiring. But that could be a way to circumvent the problem. There is a company called...
Isn't carbocaine also like, it kind of works it's kind of already like that, where it works at a lower pH or something, and that's why it kind of is helpful to use. Because I just know anecdotally, I use it, and
epinephrine is acidic. So where carbocaine doesn't have any epinephrine, it has less sting associated with it. So that's part of it. The other part of that is the pKa of carbocaine is more in line with physiologic pH. So it stings less in and of itself. So there's two reasons why carbocaine stings less. And there's all these techniques in the dental literature that advocate for using carbocaine as your leading anesthetic, which it sounds like that's what you're working towards.
That's kind of what especially, and then I use it when patients say they've had difficulties with local anesthesia, and I just load, like you're saying, like a pre-carbocaine and then Lido.
Yep. Have you guys ever heard of On Pharma?
No.
So this is called Onset. It's an anesthetic buffering system with sodium bicarbonate. Essentially what this company did is they took carpules that were very similar to dental carpules, and they have a machine. Let's see if we can find the machine. That mixes the sodium bicarbonate with the local anesthetic in a very controlled way. I think the first version of their product, it administered it into the needle and kind of mixed on the fly, which worked okay. But I think now they mix the two. So there is a product out there. It's expensive, and each of these, I think this thing right here cost $20 last time I checked. That's very expensive to take the sting out of an injection when there's other ways to provide less stinging and a better experience for the patients, which is why we bought this stuff here. So in the office we have just the straight sodium bicarbonate. So if you ever want to use it, you can draw this up and then expel out a little bit of your local anesthetic in the syringe and then put in the sodium bicarbonate. So you can do this. And there's directions I have, if you guys want me to send it to you, on exactly the ratio, because you don't want to put too much. Sodium bicarbonate can be corrosive to tissues at high concentrations. 0.2 cc's is all you need. So you expel out 0.2 and then bring in 0.2 cc's of the sodium bicarbonate and per cartridge, and then you inject accordingly. But that's if you're doing just one or two. You don't want to get too crazy with it.
I was about to say Greenbaum already got bored.
Why is that?
He left for a second.
Bad internet.
He's looking up how expensive on pharma is. But if you look at the product details, it raises the pH of local anesthetics through buffering, resulting in over 6,000 times more of the active form of the anesthetic at the time of the injection. How does it do that? Well, the anesthetic lives in a ionized and non-ionized form. The percentage of those are dependent upon the pH at which that fluid is living in. By raising the pH of the tissues where the anesthetic is, you in essence increase the hydrophobic. It takes me forever to fully understand this, but the free base is the one that's going to penetrate through the phospholipid bilayer to penetrate the nerve and cause anesthesia. So you have a lot more of that when you have sodium bicarbonate on board. In addition, it stings a lot less. When you put things of equal pH in, you have a lot less patient perception of it. With that said, I've been following this for the past 10 years, and I know a lot of clinicians that don't think it works, but I know clinicians swear by it. And my observation is in dentistry, if it works for somebody, it doesn't work for others, it's because the others haven't figured out how to use it the way that the person who uses it does. So I am a believer of this because I know people who have done split mouth designs on their patients over a 3-month period of time and had a very profound difference in not only the onset, so it produces anesthesia more quickly, decrease pain, but also decreasing the amount of anesthetic you need in order to achieve the same result, which in the hot patient is very helpful. Well, let's ask ourselves the question, what else can we do to help patients that are in that acidic state? Definitely not the topic of where we're heading today, but let's see where it goes.
Yeah, you mentioned previously, like getting them on an NSAID, right? Like prior to.
Exactly.
You just know that this is going to be that patient.
Yep. It's a little difficult when the patient calls. Like, how do we properly identify and get that patient on an NSAID? I think is the challenge, but I think over time we can build some systems within the practice. Patient calls in pain, maybe there's a couple questions that are asked up front, and then the situation is brought to one of the doctors, and we can maybe not prescribe, but recommend that the patient takes an anti-inflammatory ahead of time. I'll be honest, I've had patients that I couldn't get numb, that I gave ibuprofen, I came back 20 minutes later and they were numb. I can't say whether it was the time or whether it was the NSAID, but I did that enough that I'm fully convinced there's something there. And like most things, it's just another tool in the toolbox.
Were you kind of referencing what you talked about at the endo course in November about the kind of pre-appointing with a Medrol dose pack?
Correct.
Antibiotic if indicated and NSAID?
Yep. Yeah, I wouldn't do the NSAID and the Medrol.
Okay.
One or the other. If I had a patient that I knew very well, had a full control over their medical history, and they didn't have any contraindications to Medrol, I would definitely do that. I don't know how I feel about antibiotics as a blanket statement. I would definitely be comfortable being more blanketed in the approach of the Medrol, again, for patients that have a medical history that supports it. But antibiotics, when the American Academy of Endo came out with their position statement on antibiotic use in odontogenic infections, they made it pretty clear we shouldn't be using them that much. So to use them in that respect, although it probably would help, it's not good. What's the term? Antibiotic Stewardship, I think is the term. How, as clinicians, how responsible are we being in the world of prescribing antibiotics? I think that might be an arena where I'd be a little careful, but I would be okay with the Medrol dose pack because of the way that the pack is set up, that there's no long-term effects, and it's likely to drastically help you clinically. So that's where I would start. Let's say the patient calls a day or two ahead of time. You don't know them that well. I would be very comfortable recommending 600 milligrams of ibuprofen every 6 hours.
For the antibiotic, it's recommended that you only prescribe it if there's like active swelling, correct?
Correct. Yeah, I mean, the whole idea is that how much blood supply is there to where the infection is hanging out when you don't have purulence. When you have purulence, the infection has made its way past the apex of the tooth. But for patients who are suffering from irreversible pulpitis, that's really the difference. Is irreversible pulpitis tends to be the most common diagnosis for patients in severe pain. Those are the patients you really want to shy away from giving antibiotics, even though anecdotally it works a lot of the time. I've worked with several associates who would do that regularly because that's just what they felt comfortable doing. And I would often recant the AAE position paper, and they were like, well, that's not how I was taught. So they did it anyways, and the patient would get better. I can't speak on much other than it's pretty clear what the literature says, what we should and shouldn't do under those circumstances, which is why I think Medrol is such a powerful tool for us, because it addresses the pain, it addresses the inflammation, and if antibiotics aren't the right call, again, if you have draining, that's a different story. But oftentimes when you have draining, you don't have pain because the pressure buildup has released. So yeah, antibiotics, I would say, are pretty rare when it comes to treating acute pain. We use a lot of antibiotics in a prophylactic manner when we do implants and surgeries. That's obviously more of a preventative measure. But when treating infections in the mouth, it's pretty rare that we're going to be using them. But there's a flip side of it. You don't want to be the dentist that didn't give your patient antibiotics. And how do you navigate those waters? Because sometimes patients will be upset. My friend Steve at work last week had an infection, and his dentist gave him an antibiotic, and you told me to take Motrin. There's no amount of patient education that's going to get them to understand why you did what you did. I wish there was a nice, clean answer. I can't say that I've never prescribed an antibiotic because I was muscled into it. I just made sure I wrote really good notes, and I tried to justify it in the notes. Maybe I was a little bit focused in putting a spotlight around certain aspects of the case. But yeah, it's not straightforward when it comes to that. But the idea of understanding the Henderson-Hasselbalch equation, although it sounds very elementary, I promise you is one of the things that we learned in early chemistry that actually has a clinical relevancy. So I think over time, getting a grasp on what that truly means, knowing how to use bicarbonate appropriately. I think it's in the office now. Some of us are using it, which is better than a year ago. Like with most things, it's just going to take time for it to become commonplace. Maybe we get to the point where the assistants just know what patients we're likely to use it for and just have it ready. Any other thoughts or questions about that? From noses to Henderson-Hasselbalch in 25 minutes. Well, I did want to go over, there were two things I was thinking about going over. One was continuing the conversation that we started last week on the double cord technique. There was more to that conversation about dye spacers, milling of crowns, I think I want to table that until we have more people here. There were a lot of people that couldn't make it tonight for a variety of reasons. Chad, do you want to go over that case together right now? I think that would be a great use of our time. I want to try to minimize how much of the patient's information shows up. So I have more or less created a HIPAA compliant set of records. So if I can display everything and then you just tell me what you want me to bring up, I can do that.
Are you talking about the one I sent you today?
Yep.
Oh, perfect. I wasn't expecting to, but that's perfect.
Great.
Yeah, it's helpful. It's just helpful too, because I think likely this is going to be a case that just transfers over. I mean, I don't even know the case. I'm just going to assume that I'm going to be able to relate it to like 6 of my other patients. So this is helpful to do.
I think it's a great one.
Great. So this is your patient, Jody. We'll
Yes.
stick to her first name. Anywhere where I had her name show up, I'll blur out before I post it.
Yeah.
But if you want to go ahead and give us a
Give me
rundown.
a second. Pull up the treatment planning sheet here.
Great.
All right, so Jody, I don't know how old she is off the top of my head. She is, I believe, somewhere in the realm of 60 years old. Her chief complaints were, I don't think my teeth are savable. I think I need dentures, and I don't like the look of my teeth. The iTero scan, I feel like it doesn't show the intrinsic staining or even the extrinsic staining quite as well as photos do. So maybe we can pull those up as well. And so, yep, there we go.
Yeah.
So some relevant history for her. She has had a history of strokes. She had one in September of last year, and then also another one in October. She's currently on aspirin for that, no other blood thinners. She currently manages chronic pain with Vicodin, has severe headaches, migraines, allergy to steroids, and then has a history of smoking less than 1 pack a day for the last 10 plus years.
Can we just rewind 2 seconds? How can you have an allergy to steroids? I understand someone's had an adverse reaction in the past, but people say that. It's not the first patient, and Regan brought it up too, and I was like, and he said like, I don't know how this patient has an allergy to a steroid, but all right. And it's like,
I can answer that very easily.
Yeah.
Patients don't know the difference between adverse reaction and allergy.
Yep.
Yeah.
So you're gonna.
I was going off of what's on medical history. So,
like, let's just say, and this is the patient where this could happen. Let's say we consult with her physician prior to, and we find out that like she could take a steroid if she got into like a severe acute pain, and that's not impossible probably for this patient. I mean, could we comfortably prescribe a Medrol dose pack, or do you think just because she said it, we could get in some?
Look, can I say something real quick?
Yeah, go for it, Chad.
Yeah.
So on the medical history, it was kind of interesting. So she marked yes to like allergy to steroids or something like that, and then drew like a little arrow and said stroke symptoms.
Oh.
So because of that, it makes you want to stay very, very clear of that at the off chance that there is something a little bit more adverse than the normal reaction.
Okay.
Do that, especially because she just had 2 strokes last year.
Yeah, that's freaky. Okay, cool.
Anyway, so the problem list that I kind of compiled for her is multiple missing back teeth, severe staining, super eruption of teeth in spaces causing minimal restorative space in the opposing area, mild to moderate rotations on her anterior teeth, moderate wear and chipping on the front teeth. She has a retained lower left wisdom tooth, multiple sites of moderate decay, and an abscess number 7, which is the main reason she was in today, or I guess last week I saw her. Her overall desires and goals are kind of twofold. She function anesthetics. she is not able to chew very well, then she hates the look of her teeth. She doesn't smile. She hides her teeth as much as possible. So, do you want to kind of flip through some of those other pictures real quick?
Sure. When we do the problem list, and you did a fabulous job. So me adding a few things is not anything other than just adding perspective, but spot on everywhere. Looking at the soft tissues and the CAT scan to make a comment whether they've lost zone of keratinized tissue is one that you want to comment on.
Okay.
You can see here when we remove teeth, the zone of keratin or the mucogingival junction often ends up getting lingualized. So if we were to place implants here, I don't want to say this is bad. This actually isn't that bad. But there are times where the mucogingival junction is like on top of the ridge or even lingual. There's all kinds of ways to solve that. Topic for another day. But making sure patients understand that they lost normal tissues when they lost teeth. So I'll often say when you lose teeth, you lose two other things, bone and soft tissue. And sometimes we have to build those back up. Sometimes we don't. So that would be just one observation. We tend to look at teeth. We're dentists. We're trained to look at teeth and problems with teeth. But when you do these bigger plans, taking a step back and looking at the tissues.
So in this case, you would say that she has lost some tissues in that area, or
keratinized tissue. Yep. Okay. Diminished zone of keratinized tissue.
Okay, and then I definitely want you to show the her profile, or not her profile, her full face photos, if you're able to.
I can't, only because of the way I set this up, trying to keep it HIPAA compliant.
Okay.
What part of it? Because I do have these photos.
Yep.
So getting a sense of where her incisal edge is in relation to her lower lip is always a question we want to ask.
Yep.
I think honestly it's really not that bad, maybe just a little bit short.
No.
What was it about the face photos that you wanted to comment
I think
on?
it showed just how dark her teeth were to her face.
Sure.
They look darker when they're in her full face rather than just the retracted view, in my opinion.
Right.
But not a huge deal to not show that. But
on a scale of 1 to 10, how important is it for her to improve her the color of her teeth?
I think it's high on her list.
Yeah. Was that something she brought to your attention?
Yeah, she said she doesn't like the look of her teeth at all.
So one of the things that's important, when patients say that, writing down exactly how they say it and then mirroring that comment every time you see them.
Yeah.
So that's a technique. Mirroring is a way to speak to people's emotions without offending them, because it's the words they used. So as they receive the words that they used, it doesn't inflict any sort of negative reaction. You could say the same thing a different way and upset the patient.
Yeah.
The classic example is, I want to chew steak. Just come back to it. I mean, don't beat a dead horse, but make sure to do that. So however she articulated this, she might have been a little bit general, saying, I hate my teeth. Obviously, you're not going to want to use the word hate. But thinking this way and how we talk to our patients is truly what makes the difference between them understanding that you're compassionate, that you listen to their needs, but also keeping them in a mental state that allows them to want to do something positive.
Yep. Does anyone have any other findings that they see that not?
I mean, I think this was implied, but do you consider her having like a reverse smile line because of this? Like, I think it's implied because of the superruption of her back teeth, but and I don't,
mostly because of number 12 right there.
12, yeah.
Yeah.
Yeah, super good catch. Saying super eruption doesn't mean much to the patient. A reverse smile curve definitely does. To us, we're saying the same thing. Solving this is not very difficult when you're doing a full mouth rehab, because you just prep the tooth accordingly.
Yeah.
but it is a good reason to build value in the eyes of the patient as far as doing something more comprehensive. So I love reverse smile line.
As far as perio goes, I need to take a closer look at the perio charting, but overall, her tissues look pretty healthy. I think it's mostly because of the smoking in terms of the decreased inflammation than what there should be, would be my guess.
Yep.
Or at least decreased bleeding. And then also the mesially tipped lower molars.
Yeah. Yeah, those are always important to have in the equation. And I think you guys have done several workups and you've always accounted for these. A great example of how we can incorporate these into the treatment plan is if you're going to do a partial, crowning the tooth so that you can create a rest seat that's in a very different position than the current rest seat, and a guide plane to help hold the tooth up during function. If we try to put a partial on these teeth, let's say these teeth are not ridden with caries, and we created a rest seat here, biomechanically that's not very favorable. By crowning the tooth or reshaping it, doing an enamelplasty, you can definitely improve the biomechanics of the partial, the fit of the partial, the stability of the partial. So when we talk about partials, we tend to think of, we're trying to give the patient the most cost-conscious option.
Yeah.
Nothing makes for a bad day more than trying to give a patient a partial because they couldn't afford anything and it not fit well, and then you have to redo it. They have to come back. That same patient can't afford to come back 10 times to fix it right. So always thinking ahead when you make these decisions, making sure you understand the potential pitfalls of certain treatments. It just saves headaches in the long run, and that's why we meet, is to go over what are these potential pitfalls. Has one of us had a case where on the surface it looked easy, and then we realized that there was a component of the case that really sent the case in the direction that nobody wants, and the whole goal is to prevent that from happening. Tilted lower second molars are one of those things. Never take them for what they are. Always try to think about how to solve the fact that they're tilted, either through uprighting or crowning or enamelplasty or removal. I don't think these should come out, but there are times when they should.
I can kind of break down through my options if there's nothing else to address problem-wise.
So you and I haven't gone through this case yet, only because you just sent the email. But
correct.
When you do the workup, are you going through the CAT scan?
So I don't have access to it without being in the office. So I was going to go through it when I am there tomorrow, just to buy everything. And I also have had minimal, experience with reading them, so
sure,
I'm gonna be kind of relying on you for that end of it for sure.
Great. Well, let's do it now. But if you want to follow up tomorrow, I'll be in the office. So when I do evaluations of the CAT scan, here's the thought process I go through. And I do have a YouTube video on the channel that kind of walks through this in more detail if you guys want to find that lesson. But I treat it almost like perio probing. I start in the upper right, and then I go to the upper left, then I come down to the lower left and go to the lower right. So I'm not trying to look at too much at any one point in time. And before I do that, I'm going to take a general look at whether or not there's asymmetry or not. So I'm going to be looking right here in the axial view. And I'm just looking left to right to make sure there's no radial opacities, radiolucencies, anything that's asymmetrical that I can't describe. I'm getting a sense of their airway. Is there anything in their spinal column? I'm not an expert in the spinal column, but I'm an expert in asymmetry. I can definitely identify when things look different left to right. So that's all I'm looking for. And the reason why this is important if you're going to do a treatment plan for a patient that involves implants, you really need to answer the question, does the patient need bone grafting?
Yeah.
That makes a huge difference. Sinuses are open. The nasal turbinates look enlarged, which isn't surprising considering most people have enlarged turbinates.
Does smoking add to that at all?
It does.
I don't know. Yeah.
Yeah,
They have like really thick tissue sometimes in their sinuses, right?
Yep. The place to look at the turbinates is right here under the section view. And then you scroll back and forth like this. Those are very large. That's basically what mine look like on my left side. Right side. So she could definitely benefit from it, or she could benefit from not smoking. You can see her turbinates. Her septum deviates to the side. So, anyways, sorry.
Since we're not ENTs, do you add those to the problem list, or do we just bring them up in the consultation and say, "This is for your information"?
Yeah, you're not diagnosing when you say enlarged turbinates. I would just make sure that if you identified that you follow through with some sort of recommendation for an ENT follow-up.
Same with the deviated septum?
Yep. Lots of people are going to say, oh, I've had a deviated septum my whole life. We'll let the ENT decide whether or not that needs to be fixed or not. Would I send this patient? Honestly, I think everybody should see the ENT. I don't think I'm at the point where I can look at the degree of the turbinates and say whether or not they need to go to the ENT. When I was there for my appointment, I tried to get him to shed some light on that. He was rather dismissive with me. I think most medical clinicians they don't want to talk to dentists about anything, is really the take-home message. But I think over time we're going to learn to maybe classify or categorize the degree of severity of these, and then have very clear protocols on what to do when. If she is smoking, my guess is it's the smoking that's causing this, and I would just educate her that she should see an ENT, but I wouldn't hold up the case for it. If she had thickened sinus membranes in the Schneiderian membrane and we needed to do sinus lifts, then I would probably say yes, we need an ENT to look at this. So getting a sense of their airway, getting a sense of any asymmetries, I really don't see anything. So then I come over to the arch section, and what I'm doing, I put the green line here, and I start just distal to number 2 or number 1, and I'm looking here. So I'm scrolling here, but I'm looking at the apex at this orthogonal view from a PA. So a PA is left to right. This is a 90-degree image to that, and you're going to see lots of things here that you probably would never see on a PA. So that's what I'm looking for. And obviously experience helps. I don't see anything here other than she has a pneumatized sinus. Smokers have a higher degree of pneumatization in the sinus. Is that a problem? No, that's just a finding. You can decide whether or not you want to bring attention to that. So there's a little bit of sinus thickening here. Why do we have sinus thickening that's not generalized? From a multitude of reasons. Most of the time it is from a tooth infection. So whenever I see that sinus infection, I'm going to slow down a little bit and try to see if I can see any periapical issues.
I do.
Is this
remember
what?
There is distal caries on that tooth. I remember it for sure.
Yeah, Jason, what were you saying?
Yeah, this is, well, it looks like there's a huge amalgam, something sitting in like the something close to the nerve. This is probably a tooth with some periapical pathology, and then it's ended up in, I forget what you call it, something mucositis. I don't know, but it's Labani had a case like this, and the guy, the guy called because he went to an ENT who told him he had cancer, nasal tumor, and he just had that. He had like an odontogenic infection that led to like nasal mucositis.
Yeah.
Yeah, it was like a gross. It was that patient that I had messaged you about. I sent them to the endodontist. He said, "Oh, I didn't know I needed a root canal," and then you messaged back saying I told him. So
Oh,
he had
that guy.
he had a whole runaround with other doctors, and they said, "We think you have cancer because you had a pneumatized sinus." So the whole family was throwing around the cancer word. There was a lot of crying. There was a lot of like emotions. And then
Wow.
they took a biopsy. They did a same day biopsy of the sinus. Realized, oh, hey, this has an odontogenic origin, and then said you should follow up with your dentist. And then we were like, yeah, we told them he has a root canal that needs to be done. Like we could have told you that was just a secondary finding or related to the root canal that needs to be done.
That's insane. I mean,
And they were like so relieved, and I was like, look, like take the deal with the elephant in the room, take care of the root canal, see if the sinus relieves.
Right.
Like, that does not look like cancer. I'm not saying it's not. I'm just saying like that looks like a pneumatized sinus from an odontogenic infection in a tooth.
Yeah. So pneumatization and mucositis and inflammation are different. Pneumatization is enlargement of the sinus. If you have chronic inflammation of the Schneiderian membrane, the underlying bone melts away. That's pneumatization. That is different than thickening of the sinus membrane that shows up as a polyp or an area very similar to what we were looking at. You know, thickening, this could just be mucus buildup. It could be thickening in response to the tooth. But always making sure we use pneumatization properly. Just want to make sure that we are on the same page there. Yeah, Christian, let's talk more about that case, because I thought we were pretty clear with the guy what we were trying to do. You know, go get the root canal so that we can move forward. Who told him he had cancer?
One of his MDs.
Jesus.
Yeah.
So I'm coming around. I'm looking at the apices of the teeth. I'm looking at the bone.
Can you go back to number 7, Chad? What was the tooth that had the abscess?
It was number 7. I don't know if it may have just been symptomatic apical. It may have not been abscess. I couldn't remember off the top of my head. I have to go back to.
So the patient said, like, "Oh, my tooth is abscess because it hurts."
No. We tested it at that appointment, and it was necrotic.
Gotcha.
Yeah,
It had a large composite filling into it, and it down to the nerve, and so I think it was just pushed past its.
Yeah, I think you can kind of see.
I don't really see any periapical radiolucencies here.
Yeah.
But that doesn't mean that the tooth isn't necrotic.
Yeah.
And when we were looking at the photos, I didn't see any reddening up here. I would just be a little careful with your diagnosis here.
Yep.
I'll
double check that.
As with all endodontic diagnoses, always double check.
Yeah.
This one just smells a little. It could be something else.
Mm.
And always remember that when a patient responds negatively to the cold test, does not mean necrosis.
Mm.
So I'm being very putting a spotlight on what you just said. It matters. So when we say necrosis is an aggregate of many clinical signs and symptoms, not just a negative test on the endo ice. So if you have endo ice, that's negative. Then you do an EPT, that's negative.
Let me pull up the note and see what we did. I'm having trouble remembering it all.
I mean, how's this for a thought experiment? Can you diagnose pulpal necrosis when you have negative EPT, negative cold test, and no periapical findings?
No.
I mean, I think I would write strong evidence to suggest pulpal necrosis based on those findings. And like Chad just said, like I would also say, and clearly, clinically and radiographically, there's a large restoration essentially nearing the pulp or into the pulp, and all of these things would suggest. And I think I've said that in my notes before, that, you know, like strong evidence, or there's a lot of supporting evidence to say.
Yeah. I like that wording, but I'd be careful with the word diagnosis.
Yeah. Are you hinting that a calcified canal can have the same result?
Correct, and still be vital.
Yes.
You know, I've gone into cases like this and it bled. Endodontic diagnosis is hard, you know, at the end of the day, and just being very aware of how we come to conclusions will prevent us from working on wrong teeth, working on teeth that didn't need it. I don't think you're off here. I just wanted to use the opportunity.
It was positive to percussion and non-responsive to cold.
Yeah, you know, those things don't typically show up in the same tooth, which is why I'm a little bit, I'd be a little bit careful.
Okay.
Most likely, that's a trauma-induced periapical periodontitis with a normal nerve that's just not testing because it's calcified.
Okay. Even if the adjacents, she responded normally?
Yeah, I mean, adjacents are not, they're helpful information, but they're a little bit self-limiting in their degree of helpfulness.
Yeah.
Adjacent teeth shed some light on how much validity you can put to the test.
Yeah.
But that's it.
So then if this is where she's experiencing pain, though, then what do you do?
Whenever I have an endodontic diagnosis that doesn't make sense, I always want to go to the trigger points. I don't think that's necessarily what it is, but there is a referral pattern from the anterior temporalis that refers to this area. So that would be my first thing. I would just kind of massage her temple, you know where to palpate the temporalis. It's not the temple, it's a little bit behind that. Look at the trigger point referral patterns in the packet that we went over in the fall. If that's not it, then I would look at the occlusion. So let's go back to...
Yeah, I was just going to say, can you show that occlusal view? I don't even know if it'll show it, but...
You know, looking at this here, I don't see anything periodontally. She has entrapment. What is entrapment? It's when the upper teeth are in the way of the lower teeth. We know that because of the strong blue marks that are located on the facial surfaces of the lower teeth. That's not normal. Ideally, none of these teeth touch in MIP or CO. We call that long centric. The idea is that the mandible wants to be free when it brings the teeth together, and that freedom comes from the front teeth not touching. People who are untrapped, the teeth are touching. When the teeth touch in MIP, their muscles activate and they wear away their natural teeth. So whenever you see the blue or gray hue of anterior teeth, 9 times out of 10 they have entrapment. Well, entrapment happens in phases. It might have been this tooth when she was 20, this tooth when she was 30, now she's 60, 65, and it's maybe this tooth. But rather than the enamel giving way, it's actually her apex that's starting to get jostled a little bit. When we have nathologic stress in the system, it always manifests itself differently. Sometimes it's broken teeth, sometimes it's inflamed joints, sometimes it's painful muscles, sometimes it's pulp stones or calcifications, and sometimes it's periapical periodontitis. So the first thing I would do, if you're not able to see anything radiographically here, pain on percussion is really the only thing that you can do to give you some sort of sense of the diagnosis. Again, negative cold test is only part of the equation. That doesn't give you a diagnosis. I would adjust this occlusion a little bit and ask her how she feels. And I bet if you put your finger on this guy and you have her tap, 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 you're gonna feel it deflect. Then you adjust it, and she goes, "Oh my goodness, I feel so much better." It's literally a life-changing thing when that's the problem. So it's a very easy test. You just have to let her get you adjust these blue dots.
Okay.
This blue dot right here, really, that whole thing needs to be removed. There's nothing about that blue dot that is part of a stable occlusion. This whole area right here needs to be removed. This needs to be removed unless Chantel had her grind. So you need.
Can you show the occlusal view
Sure.
of this?
That there?
No, of the maxilla.
That one?
Yeah, now I just have to reorient myself. Okay, so that's 12. This has a large composite on it too, like really large composite.
Do you have the PA available, Dr. Roy?
Yeah, that would be cool to see.
I just pulled it up on my end here, and it's a very significantly deep composite.
I don't know if a deep composite tells you anything though.
Yeah, it's a part of the
Supporting
puzzle,
factor.
I guess.
In this case here, I don't think it tells you anything, and
Okay.
I'm not trying to be a contrarian here, but I don't think that information would add anything to the diagnosis. If I knew it was necrotic and I had that deep one, I'd be like, well, it's a deep filling, and that's why it happened. But it's not going to give me a diagnosis until I see something on the X-ray that shows me a periapical pathology. To then conclude that the patient has pulpal necrosis, that big filling means nothing, because big fillings all day long can be placed and you can have vital canals.
Okay.
This is occlusal, 100%.
Okay.
Yep. You adjust that, and she'll be your best friend. Educate her on when we do equilibrations. Sometimes we send the system into disarray, but we know how to solve those things. So always educating the patients when we do equilibrations that her body might not like what we do, even though it needs to be done.